I have the slide projected. The topic of my talk is how arteries age in diabetes, intersections between metabolism, inflammation, and genetics. And of course, this is a complicated topic. And most clinicians do not know all the fine details. I don't know them either. But I will try to give an overview. And the interesting perspective is that you can look upon this from two sides, from the bad side or from the good side. From the bad side means that we have to understand vascular aging, atherosclerosis, and risk in diabetes, and all these mechanisms that could eventually one day turn into novel drug targets. But the good perspective is to look for so-called escapers, people who escape complications despite many years of diabetes. Why are they protected? Like type 1 diabetes for 50 years, no signs of major cardiovascular complications or diabetes nephropathy. So even if these escapers are rare, they are extremely interesting from a scientific point of view, because if we can find some protective mechanism, these can turn eventually into new drug targets. So I will bring you both perspectives, the bad one and the good one, to increase our understanding and the discussion. Let's start with vascular aging in diabetes. You know, this is a model of early vascular aging, EVA, in diabetes, with so many things that can go wrong. Atherosclerosis, arteriosclerosis, increased risk of thromboembolism, the chronic inflammation. It's a perfect storm for cardiovascular complications. You know it well. And if we take a closer look, we see that diabetes might affect both the microvasculature and the macrovasculature that can be discussed according to macroangiopathy and microangiopathy. There are many examples of this. And of course, glycemic control and diabetes duration are common denominator in the background. Otherwise, they have a little bit different risk factor patterns. And the UK PDS study once showed that treatment of hypertension, high blood pressure, could protect you from retinopathy. This means that some treatment modalities, not only to lower glycemia, but also to treat risk factors like lipids and blood pressure, could bring benefits for the macrovascular complications, but also for the microvascular complications. Earlier today, we heard lectures on diabetes and the brain, diabetes and the central and peripheral nervous system, and of course, vascular dysfunction could also impact on nervous function in various ways. To the left, you see atherosclerosis that primarily affects the arterial intima with plaque formation, plaque rupture, and I will come back to the specific properties of atheroma that are prone to rupture in diabetes, and some modern findings that could increase our understanding. Over the last few years, I've been interested very much in what you see to the right, arteriosclerosis, arterial stiffness affecting the arterial media. Of course, wherever these processes start, by aging, they get intertwined and they modify each other, and in the end, there is a synergistic increased risk of cardiovascular complications. But atherosclerosis is so well studied, and we have drugs and interventions to address it. But on the other hand, arteriosclerosis is still in search of a perfect treatment to treat arterial stiffness. We can do it by treating blood pressure, hypertension, but people think that some newer experimental drugs could eventually bring a reduction of arterial stiffness, arteriosclerosis. On the slide, you see so many of these systems that are activated in vascular aging in diabetes. More or less, I would say during one time period, some of these mechanisms might be more important than the other ones, but during other time periods, other mechanisms could be predominating. But in the background, there is the aging process itself, the cellular senescence, and many people have been thinking about whether atherosclerosis is associated with what we call normal aging or not. We know that from indigenous populations, there are studies to show no specific atherosclerosis. On the other hand, the old mummies from ancient Egypt have shown signs of atherosclerosis. So it's an old phenomenon. I will not go into all these fancy details, but the common final pathway is vascular aging, early vascular aging, that links to the model of diabetes in poor control represented early biological aging. And therefore, it's no wonder that these patients are harmed by so many complications also associated with aging itself. Hyperglycemia and insulin resistance are very important players in the background. And during the course of development of type 2 diabetes, you know there are different stages, insulin resistance, and later on beta cell dysfunction and hypoinsulinemia. So the diabetes duration, the beta cell properties and susceptibility will all be important to change the time course of the events. Some patients will have a more rapid progression of their diabetes and diabetes complications, but on the other hand, there might be patients with a much slower development. And even if many patients develop the bad things, like neuropathy that we heard about, one could ask, why do not all patients with diabetes develop neuropathy? Why are some spared? Why are some exceptions? And I think we should study the extremes, the exceptions. In clinical care, they do not matter so much because they are rare. But in science and for scientific development and to target novel drug targets, they are extremely interesting, and I will come back on this. I'm interested in babies. Maybe it's because I'm a grandfather myself, but I love babies, and I love research on babies. And over the last few years, I've been addressing early life programming because it's a simple fact of life that we all undergo aging, and we have all been babies, haven't we? So there is something called the first 1,000 days of life, including the pregnancy period and the first 2 years of life, of great importance to influence growth, metabolism, vascular function, the gastrointestinal microbiota patterns, inflammatory responses, etc. This is not deterministic. It doesn't mean that all premature babies or small for gestational age babies should end up with type 2 diabetes or myocardial infarction, but it's like a risk modifier. And I think we should take this into consideration. And to me, it brings a very positive argument to support and strengthen preventive maternal health care and child health care also in this perspective. And coming back now to type 2 diabetes, we know that some adverse factors in early life, like small babies, low birth weight babies, premature babies, are at increased risk of type 2 diabetes for various reasons, like deficiencies in beta cell turnover rate, etc. But more interestingly now, when we speak about vascular aging, is this study from Denmark in more than 8,000 type 2 diabetes patients, when it was revealed that low birth weight is also associated with the cardiovascular complications, events, and mortality, as can be seen from this slide. So it means that some early life programming factors could play on several mechanisms, like vascular function, like capillary rarefication, like intima and media structure, elastin content, so many factors that later on will meet the diabetic state and be influenced. Glycosylation of proteins, stiffness of the arterial wall, inflammation. They play on the piano, and the piano is pre-programmed during fetal life. You see the white and black bars of the piano are pre-formed during fetal life. So adverse risk factors in adult life, including adverse lifestyle, they all play on the piano. But there must be a piano. There must be biology and a body and structures pre-formed during early life, also in early childhood, as a substrate for all these mechanisms. Let's talk about some genetic links. And there was a recent very good review paper I can recommend to you in Diabetologia a few months ago, exploring the shared genetic landscape of diabetes and cardiovascular disease, findings and future implications. The bottom line is that in modern genetics, we can do mapping of different things. And then we can use advanced analysis called Mendelian randomization methodology to dissect causality, because causality is the most important factor. If something is causally related to something else, it means that there is a chance that we can intervene, we can treat, we can achieve benefits. But if there is no causality at all, we are lost. So you see, whatever we find in mechanistic studies, we have to consider causality if we one day want to treat. Of course, there are plenty of biomarkers, sophisticated biomarkers, that stay as simple predictors, like biomarkers, without causality. For example, HDL cholesterol. People speculate whether it's causally related to ischemic heart disease or not. Some studies tell no. And this is why drugs to treat and increase HDL cholesterol, at least so far, have not been convincing, didn't show the benefits that we expect. So causality is the cornerstone. And in this review, they tried to bring this perspective. A lot of genetic markers are associated with type 2 diabetes, some other genetic markers with coronary artery disease, and in between them you see 145 genetic markers that are associated with both conditions. But on the other hand, there are so many type 2 diabetes genetic markers that are not associated with coronary artery disease to be used for Mendelian randomization. And therefore, we can see that many of these mechanisms, as listed here, dyslipidemia, inflammation, insulin resistance, and vascular dysfunction, could play on biology against this genetic background. This is why genetics are of importance, not so much, in my opinion, for prediction of the future of individual patients, because there are just a few conditions with very strong genetic background to make an appropriate prediction for the individual patient. But to use genetics for Mendelian randomization analysis and to tease out causality is so important to promote science and to promote the quest for novel drug targets. Here to your left, you see some markers that are associated with CVD in people with type 2 diabetes as single variants, and to the right, clusters. I will not go on into all these details. You have to be a professor in genetics to understand everything. I'm not. So I'm lost when it comes to the finer details. But then I phone an expert. You don't have to know everything yourself. You can phone an expert if you need it. So the bottom line here is that so many of the mechanisms have a genetic background. And of course, then we have the environmental influences, the lifestyle influences, and also to be remembered, in early life there is something called epigenetic programming, that some environmental factors could shape or modify or silence or turn on some genetic markers. Again, I use the symbolism of a piano. It's standing there in silence. And all the bars are the genetic factors until there is an environmental factor, the hand, to press the bars, and out comes a melody, the phenotype. So the genotype, the piano, the bars, could sometimes be just silence until there is an environmental factor to wake them up or to produce this phenotype. Impaired repair function. This is a new and interesting topic. And some of my friends back in Sweden, they are working on this, and I asked them for some slides to share here with you. As clinicians, you know that very well that people with diabetes and hyperglycemia, unfortunately, they are prone to infections. And they have a lowered defense against infections. And unfortunately, they also have impaired repair functions. So wound healing is often delayed or not complete. You know it as clinicians. And you have to provide some antibiotics or regulate the glycemic control even better to heal the wounds, like foot ulcers, etc. You know it. But my friends are interested in the atherosclerotic cap. And their finding is that the fibrotic cap in patients with diabetes is thinner and more prone to rupture than the fibrotic cap of non-diabetic patients. So maybe it's just the loss of repair function that provokes plaque rupture on the road down to cardiovascular events. We know that chronic inflammation could play a role, lipid metabolism, and so many adverse factors. But it's good to think about that the similarities between defects in wound healing in the skin or the foot is comparable to defects in wound healing repair of the plaque cap. And that could mean disaster, could mean rupture. And on this slide, you see contractile vascular smooth muscle cell to your left and synthetic vascular smooth muscle cell to your right. And they are like differentiated in the plaque. But there is something called transforming growth factor beta that is an important player to modify the collagen content of the fibrotic cap. And in patients with diabetes, many times this transforming growth factor beta 2 is downregulated. It's lower than normal. And by various mechanisms, it can impact on the fibrotic cap or the plaque to make it weaker, thinner, with less collagen and more prone to rupture. So there is a balance between repair and inflammation. My friends are shown here, Andreas Edsfeldt and Isabel Gonsalves at the Lund University, and they ask vascular surgeons for plaques when they do carotid surgery from patients with diabetes or without diabetes. And of course, then they try to do histology when they examine all these plaques. And the bottom line is that they find that atheroma in patients with diabetes are different from atheroma in patients without diabetes, more prone to rupture and less stable. In one observational study, they could see that the level of plaque oxidized LDL was low in type 2 diabetes from the population because of heavy statin treatment. but they could also show that the content of oxidized LDL was not predictive of future cardiovascular events as expected, but the loss of repair function and this transforming growth factor beta 2 was predictive. So there is something wrong with the plaque proneness to rupture in patients with diabetes. And if we can understand this and control it, it can bring some novel drug targets for the future. Let's go to my favorite topic. For years and years, I've been focusing on the bad things, risk factors, events, complications, morbidity, mortality. I'm fed up with that, to be honest with you. I spent too much time on that. So now I'm looking for protection, resilience, and models in medicine where this could be further explored. Today there was a session on fatty liver disease. And even if most people with obesity develop fatty liver disease, various definitions, just a few escape it. Even if they have type 2 diabetes, rare, few, but we could learn so much more from them. And now I bring you type 1 diabetes escape as a model of vascular protection that we are currently very interested in. So this phenomenon can be studied various ways, from epidemiology, different mechanisms. Are there true protective factors or not? Is it treatment related? Could there be the influence of mental and cognitive aspects, personality, coping behavior, and also the social network support? Or is it just coincidence or random effect? Because in biology, we always have to calculate that there could be a random influence in everything we see. But still, there are cohorts to show this. And one of the most famous one, you know it, is the Joslin Diabetes Clinic Medalist Cohort. Since more than 50 years, patients with diabetes of long duration have been awarded a medal from the Joslin Diabetes Clinic. It's a bit unfair because many of them are not true escapers. They are survivors. They had an event, but they survived. Or delayers. They waited very long for the complication, but finally it got them. Just a few of them are true escapers. No signs of major cardiovascular or renal complications. I'm not speaking about very mild complications, like a little microalbuminuria. I'm not interested in that. I'm speaking about avoiding the major complications. And the PI of this famous cohort is Professor George King from the Joslin Diabetes Clinic, well known, and he has studied now more than 1,000 type 1 diabetes patients with more than 50 years duration. A few have even survived 80 years plus. With an interest in various mechanisms. I will not go into the details today, but residual beta cell function could be a part of the explanation. In Finland, they have a beautiful cohort called Findian. Patients with type 1 diabetes followed for a very long period of time. PI used to be Per Henrik Groop. Now he has been succeeded by other people. But the most interesting thing to me was that 15% of 729 patients with more than 50 years duration had no signs of advanced diabetes complications. And please notice they started insulin treatment in the old days before human recombinant insulin or multi-dose insulin. So that was the poor old insulin treatment strategy long time ago. But still, such patients can be found. In Malmö, Sweden, we have now for a few years invited the true type 1 diabetes individuals with no history of major diabetes complications, the true escapers. So the difference between our cohort and the Joslin medalist is that they have a mixed bag awarded people. But we have on purpose selected the true escapers to learn more about them. And we do MRI of the heart and aorta and also some proteomics. We are in the process to map different protein patterns reflecting different mechanisms, comparing one group with escapers with another control group of so-called rapid progressors with early complications. So we want to study the cardiovascular system, vascular function, in association with protein patterns, etc., to find eventually protective mechanism. And this is just the first publication. My colleagues are listed here. And not so interesting details so far, but we have more to come. And the most recent data are super interesting because we did cognitive testing on these escapers compared to a healthy, normal, cognitive, normal control group matched for age, sex, and education level. And they did fairly well, but one test was better than the controls. Oh, there is a test when you see a face and a label of the occupation. And then after 10 minutes, you see only the face, and you have to select the right occupation and to link it with the face. And they did better. Why? Maybe they are more extrovert, more interested in people, more social people, and they got mental resilience. It's not only biology, it's something in the head. Because you as clinicians know that patients suffering from a chronic disease burden are often depressed. They are burdened. But a few of them seems to tolerate this burden better than other ones. Why? It's a matter of coping, cognition, personality, and other factors that we want to bring into the picture. Other people have been thinking along the same lines, and this is a paper from Diabetologia 2021 describing some of the potential mechanism of interest that could be linked to this escaper phenomenon in long-standing type 1 diabetes. And as I told you now several times, the ultimate goal, the ambition, is to find the new therapeutic targets. If we can map some protective mechanism, if there are any, we don't know. It could be the bad genes turned off, loss of function genetics, could be something else. But we and others are on track to do this. And from the Joslin Diabetes Clinic, they published the most extensive review paper I found so far on protective factors and the pathogenesis of complications in diabetes. And in the right box, you see some systemic and tissue-specific protective factors that they have been researching. They are still not at goal, but some of these factors could eventually be explored for novel drug targets in the future. They also introduce another concept. When we speak about diabetes complications, we separate the macro and microvascular complications, but they tell about vascular tissue disease and parenchymal tissue disease and the mixed category here in the middle. So they have some new ideas about defining diabetes complications based on these mechanisms. And for those of you who are interested, they also in this publication listed several protective factors against chronic complications of diabetes. However, the shortcoming of this is it looks back. It looks what has been published in the past. It's not looking to the future. So we need this information, of course we do, but we also have to do new explorative studies mapping proteomics, genomics, metabolomics to find patterns linked to mechanisms. And in Malmö, one of my colleagues has also found a special modified apolipoprotein B100 that is associated with a less coronary atherosclerosis and retinopathy in long-term type 1 diabetes. So maybe there are some lipid markers that are associated with protection to be further explored. So in summary, I discussed that atheroma in diabetes are more prone to rupture due to thinner fibrotic cap, less collagen. And this defect in repair function could be perhaps modified by new treatment. Then I told you about the escape phenomenon and that there are some cohorts with biobanks. My hope is that we can work together and find some new protective mechanisms to be further explored. Thank you very much.